All right, so we're going to look at cold and superficial heating modalities. So it should be noted that the heating modalities we're going to be talking about strictly refer to those that heat superficially on the body. So there are other heat modalities that we're going to talk about later on in the course. This one's going to center around superficial heat and the means by which we do that process of the superficial heat conduction. So first, again, to kind of understand all these physical agents, you have to understand how energy transfers. So again, there's some science behind this, as I've discussed. So we're going to look at energy transfer, and when we're looking at thermal modalities and cryotherapy, we're essentially looking at a transfer of heat. So that's always something important. Whether you're applying cold or heat to the body, it's always an exchange of heat that actually takes place. Okay, so in other words, in science, okay, physical science, cold doesn't exist. Cold is just the absence of heat. So when you're putting an ice bag on somebody, you're not per se delivering cold to the body, you're extracting heat from the body, and that's why the area then gets cold or the temperature drops. So if to talk about the means of energy transfer, so there's four means we're going to look at. There's conduction. Okay, conduction is when you have the transfer of heat through direct contact between two objects. Convection is anytime you have a transfer of heat by the movement of air or liquid between regions of unequal temperature. You have radiation, which is when energy is emitted from surfaces with temperatures above absolute zero. So that's radiation, or radiant energy conduction. And then you have conversion. Conversion is when energy is changed from one form to another. Okay, so actually all of these apply to what we're looking at right now, except for conversion. Okay, because conversion is going to deal with some other modalities we're going to look at. So what I want you to kind of just do on your own, and you can do this in conjunction with the assigned readings, is look at practical examples or start thinking about what modalities we're going to utilize and how they transfer energy. Okay, because like for instance, an ice bag has one mode of energy transfer, a whirlpool will have another. So kind of look at that in your readings, and it'll certainly be something that we further discuss in class. Okay, so cryotherapy, or the use for cold for therapeutic purposes. We're going to look at some general ideas here on cold modality. So first of all, cryokinetics, just to define that. So cryokinetics literally means cold in motion. So cryokinetics is the combination of alternating cold with exercise, so some sort of cold modality with exercise. We'll be definitely going over some examples of that. Despite there's a lot of use for cold therapy. However, there's some research out there looking at the benefits of cold application. So we'll kind of talk about, what parameters are commonly used regarding both cryokinetics and just any kind of cryotherapy in general. But just know that more research is certainly needed on a lot of this information. So when we're obviously looking at creating a temperature decrease. Now, as I said earlier, you're always looking at a transfer of heat. So kind of getting into the science part of this, when you put an ice bag on somebody, again, as I said, you're not per se causing cold to go from the ice to the body, but what you're actually doing is you're using the ice to essentially extract heat, which causes a temperature decrease in the area. Now, as the temperature decreases in a region, there's a couple things you have to note. One, it's going to be affected by the amount of adipose tissue in the area. Okay, so the amount of body fat in the area is going to impact how much of a temperature decrease you have. And that could also impact your treatment times. We'll talk about how, the treatment time for ice might vary depending upon the body part, the size of the area, what have you. So now we obviously know we're going to get a temperature decrease. So when we kind of look at superficial versus deep tissue, initially there's going to be a rapid change superficially, which would make sense. Okay, so the skin, superficial area, you're going to have a rapid decrease in temperature, which then will start to taper off a little bit. So there'll be a really rapid decrease in temperature superficially, and then it'll gradually start to taper off as time goes on, obviously because the temperature differential between what you're doing with the cold modality in the skin starts to equal out a little bit more. Now, the deep tissue does something much different. Obviously, we know that the deeper tissue is going to cool more slowly because it's going to obviously take some more time for that heat to get extracted, if you will, and to a degree a lesser extent. However, the interesting thing to note about deep tissue is that once you remove the cold, the temperature will actually continue to decrease in the deeper tissue. So in other words, when you remove the, let's just say again for the sake of simplicity, we're talking about an ice bag. When you remove the ice bag, you're actually going to still get a gradual decrease in temperature at the deeper tissue. And primarily the reason why that's happening is because you're still having temperature exchange between the layers. So the deep tissue is going to still continue to cool once you remove the actual ice. Now, as far as how long the area will remain with lowered temperature and everything, some of that will be impacted by whether or not activity is conducted after the application. So in other words, if somebody puts, say someone ices their knee for a set amount of time, but then they immediately get up and walk, or say they actually, it's very commonplace in a lot of athletic training facilities for patients to wrap their ice on and then walk out of the room. That's going to impact your temperature decrease. So that's something important to note. Now, for efficiency's sake, you're not necessarily going to have every single person stay in the facility to ice when they're done. They may take their ice to go wrapped on or something like that, but then that's going to impact your treatment time. So that's kind of something important to kind of note after the application is done. So it's important to note that a 20 to 30 minute ice pack application could have effects for 2 hours or more. So what that does is you have to allow for a warming period of at least twice the cooling. So again, we'll talk about parameters later on, but this is an important thing to note because again, you want to make sure that you don't cause any harm to the region. And for the most part, people with healthy circulation are not going to have a whole lot of issues with ice, even if they ice for a little bit longer. But that's something you want to note when you're kind of giving your parameters for home treatment. And again, activity after application, as I talked about, affects rewarming. So the rewarming is going to occur much faster if activity is conducted after the ice happens. Okay, so it's important to note that your skin temperature could also remain below normal temperature for 1 hour after a 30-minute application. So that just kind of goes towards, again, this whole idea of allowing rewarming to take place when you're done or in between your treatments if you're having somebody ice, continuously over the course of the day. So looking at some of the physiologic responses to cryotherapy, so with all these physical agents, it's important to know how they're actually affecting the body. So we know that superficially you're going to get vasoconstriction. So this affects blood flow to the skin. So you're going to get your superficial vasoconstriction because of the decrease in temperature. What's going to happen in the deeper tissue is going to be much different than what happens superficially. So again, both the cold modalities and the heating modalities that we're talking about, their primary effects in both instances are superficial. Now, cold's a little unique in that because of the exchange, because of how the heat exchange takes place, you do get significant decreases in deep tissue temperature, whereas with superficial heat you do not. Okay, but it's for different reasons. Obviously, in the superficial tissue, it's going to happen due to the direct contact with the cold, which is going to cause a temperature decrease. The deeper tissue, or the changes in blood flow to deep tissue, is going to be due to a decrease in metabolism of the tissue. So that's going to happen then as well. So as the metabolism starting to decrease, which is in theory is one of the reasons why you would use cryotherapy in the early stages of injury, that's going to cause a decrease in blood flow, because if the metabolism is decreased, you don't need as much oxygen and blood flow to the tissue. The maximum decrease in blood flow reported at 57 degrees Fahrenheit. Now, they don't know what they don't believe this will limit oxygen delivery to tissue as far as cryotherapy is concerned. One thing that will happen is you do get increased fluid viscosity. So part of the reason why you will notice some of the stiffness in tissue is because of the increased viscosity. So viscosity is resistance to movement. So the increased fluid viscosity because of the lowered temperatures are going to cause a little bit of a feeling of stiffness within the tissue, which obviously you don't have when you apply heat, because heat's going to decrease fluid viscosity in the tissue. Okay, so some other physiologic effects of cryotherapy. So we look at the effects on the nervous system, and one of the things we know is that the application of cold is going to slow nerve fiber conduction and decrease muscle spindle sensitivity. So what this basically implies is that the spasm that occurs with injury, so when you get muscle spasm due to injury, and spasm is going to intensify with injury due to increased neural input and the body basically trying to protect itself, cold will actually reduce muscle spasm via these mechanisms. So if you think a muscle spasm is almost too much nervous system input, what cold's going to do is slow that down, and it's also going to decrease the muscle spindle sensitivity. So muscle spindles are, again, they're those proprioceptors that respond to muscle length by causing contraction. So by decreasing the sensitivity of the muscle spindles, you're going to essentially decrease that input that's causing the muscle to tighten up. So you're going to get decreased gamma efferent gain, okay, which is the motor input coming into the area. Other things that occur with this, now rate of force development is decreased. We'll talk about the impact of that and what that means. Now, that's only temporary, and obviously if you're applying ice to a region, you really shouldn't be per se concerned about force development. And then you're also going to get various sensations during cold application. So kind of the sensation sequence, if you will, when you apply cold, and you'll all get to experience this, or you probably have. I mean, most people have had cold applied to their bodies before. The cold, stinging, aching, burning numbness that occurs. And again, what essentially that is just a sequence as the sensory fibers in the nervous system are kind of adapting to what it is you're doing with the cold. Now, there's conflicting findings on certain responses. So there's a lot of research out there on things like the effects of cutaneous sensation, the effect of cryotherapy on balance, proprioception, postural stability, and things like max effort jumping and agility tasks. So in other words, take the max effort jumping and agility tasks. What they look to do is apply ice and then see if the ice is going to impact the performance on jumping, agility tasks, things of that nature. The findings are kind of conflicting on all that, but when you look at it from an application standpoint, you have to be thinking about if someone needs cryotherapy that bad, should they be doing high-level athletics immediately after applying the ice? So in other words, if they need ice that badly, should they be doing that? Again, you could look at that on a case-by-case basis, but as far as any negative effects per se of ice on those things, we're not 100% sure because the findings are conflicting. So when we look at cryotherapy and acute inflammation, there's some things we're going to discuss on the next slide to kind of outline, because it's probably one of the areas where cold gets used the most. However, there could be some misunderstandings with how and why it gets used. Just another point as I kind of went through this on the applying ice and then the max effort jumps and balance activities and stuff like that. If you do have, again, whatever clinical situation where you may deem it's warranted to have an individual ice, say a joint or a muscle prior to activity, the only thing that's suggested is that you make sure that they warm up appropriately, which they should probably do anyway, just to kind of make sure that there isn't any lingering effects as far as the nervous system is concerned when they go back to activity. Okay, so again, I said that the whole cryotherapy and inflammation is a big discussion, and the most common application you'll hear, it used to be they referred to it as RICE. Well, now we're looking at what they call PRICE, which is protection protection, rest, ice, compression, and elevation. Okay, so these are kind of this is kind of the type of treatment that in most cases we use for injury care. We'll talk about the evidence behind it in class and have a little discussion about it, because there's some debate as to the merits as to how all this works. One of the things that a lot of people will commonly say is that, well, we use cold to reduce inflammation. Well, again, think about what we discussed in regards to inflammation. So inflammation is a part of the healing process. So if cold reduced inflammation, that would negatively impact healing. Now, if you are going to apply cold for these purposes, the reasons why you would be doing it is to reduce kind of what I call the secondary effects of inflammation, the pain, limit the swelling that occurs, things of that nature. That would be the reason why you would do that. So it will kind of limit the kind of side effects and some of the issues that come about with inflammation. So if we're looking at pain reduction, one of the things we know is that cold will reduce nerve conduction velocity, particularly in the slow conducting C fibers. So remember, we have A delta and C fibers. It will slow down the nerve conduction in both of those, but in particular, especially in the unmyelinated C fibers. And what that's going to do is reduce those pain signals that can reach the dorsal horn of the spinal cord. The other reason why you could potentially look at ice as a benefit is the effects of secondary tissue damage. So we had talked about during the inflammation phase where you don't not only have damage to you have the area of primary damage, but you also have secondary cells that will get damaged due to the decreased blood flow to the area, which then reduces the oxygen. You're also going to get free radical activity through the neutrophils, those early white blood cells that also damage other cells in the region. So there is potentially a benefit as far as reducing secondary tissue damage, because essentially what you're doing is you're decreasing the oxygen demand. So you're decreasing the oxygen demand, which is then going to limit that secondary tissue damage, and you could also potentially be limiting the effects as far as those neutrophils early on with the white blood cell production. So you're going to decrease that as well. So again, the early neutrophils that are going to get released with the white blood cell activity, they're also going to be responsible for some of that secondary tissue damage that occurs. So essentially, the idea, again, behind cryotherapy during the acute stage of injury is that you're obviously limiting pain. You're also going to limit swelling. So another thing to kind of note, and this will be something that comes up later as well, is that cold by itself does not reduce swelling that has already developed. Okay, so once swelling has developed or there's edema in the area, you don't get rid of that with cold. However, it could limit the amount that forms theoretically, because again, part of the reason why we have edema in the area is you have secondary tissue damage, which kind of increases the dead cell material in the area, which is going to draw more fluid in. So if you could limit that, and you could theoretically then limit the amount of swelling that occurs. But swelling that's already there does not get reduced by applying cold. There's other parts of this early treatment that can reduce it or reduce the swelling that is already formed, but cold does not do that. So cryotherapy and therapeutic exercise, this is a concept we brought up before, is the protocol of cryokinetics. So what cryokinetics is, when you see in most cryokinetic protocols, is the intermittent application of ice and alternating it with exercise. The idea behind it is that it helps to break the pain spasm pain cycle. So when you're applying the cold, you're breaking up the pain spasm pain cycle, and you're also doing something, you're reducing something called arthrogenic muscle inhibition. So what this means is, take for instance with an ankle sprain, when you sprain your ankle, or any joint for that matter, the muscles around that joint don't look to fire as much, because you have damage to the area. So one of the things that has been found with cryotherapy is that when someone has arthrogenic muscle inhibition secondary to an injury, that applying cold can actually help increase that motor pool of muscle fibers that can get recruited with activity. Okay, so there is actually some research showing that this may facilitate functional improvements, meaning that, again, take that ankle sprain, say, common cryotherapy procedure is you'll put someone in an ice bath or a cold whirlpool, you'll put them in for an initially longer period of time, have them come out, have them do some exercise. The idea is when they come out and do the exercise, you actually get an increase in the motor pool activity of the muscles in the region, okay? And actually to a greater extent than you would normally. Now, that doesn't happen in healthy people, meaning that if you have a healthy joint, sticking your ankle in ice is not going to cause your muscles to get recruited more. This will only happen in somebody with an injury. Now, one of the keys with this, though, is you sound clinical judgment. So, the patient that if they're not ready for exercise, you're not going to be able to do that. So, and basically the way you know that the patient is not ready for exercise is if the exercise results in pain that causes their movement patterns to be altered, then they're not ready for it. The other thing is patients should be able to repeat exercises during the next treatment. So in other words, say you do this with somebody and then the next day they come in and they're really sore and can't do anything. They may not be a candidate for this type of treatment. So again, if you're going to do something like this, you have to make sure that you're doing it with sound judgment, that you kind of know the degree of tissue injury that has happened before you start to utilize this type of protocol. So there's some discussion on the use of cryotherapy and the treatment of persistent pain. So when you look at kind of those long-standing type injuries or those injuries that may have had kind of an insidious onset, or maybe it's an acute injury that just kind of never really got better for some other reason. Again, cold works very well for pain modulation. So it's going to work through pain modulation in a couple different ways. So we already talked about some of the effects with the nervous system, particularly the slowing of the conduction of the nerve impulses. It's also believed that, cold, particularly intense cold, can stimulate the descending pathway of pain control. So if you recall going back to our 3 levels of pain control, okay, so that level, so for instance, level 2 pain control is the descending model. Okay, so that intense cold will actually decrease that, along with decreasing the sensitivity of the free nerve endings and slowing nerve conduction velocity. You see in this picture here, this is actually a technique that does get utilized, particularly when you get people that have a lot of myofascial pain and spasm in the upper trap. It's called the spray and stretch technique. So what this is the clinician here is delivering a cold spray, a very intense cold spray to the area. What that's going to do is desensitize the area and then permit the patient to conduct range of motion, stretching, what have you. The idea is that you're breaking that local pain spasm pain cycle by reducing the sensitivity of the region that you're treating. Now, it's going to be contraindicated for people with complex regional pain syndrome. So if you go back and think about what complex regional pain syndrome is, cold, particularly intense cold, will exacerbate that. So that will not be a treatment utilized for the pain associated with that. And again, additional research on treatment outcomes is needed. So this is something that's constantly getting looked at as far as its application. But from what we've seen so far, that we know that cold definitely has pain modulation properties. So that we know. As far as, again, clinical applications, some of that is still getting looked at, but we could certainly utilize it in regards to treating persistent pain in certain areas of the body. And that takes us to superficial heat. So superficial heat is a type of modality. Again, you can use it to decrease, like cold, it will decrease pain and muscle spasm. The important thing to note with superficial heat is the depth at which it will travel and have effects at. So again, like a lot of things, we're going to see additional research on treatment outcomes as needed. We'll be discussing research in class. An important thing to note is that the temperature increase is really primarily superficial. You're only going to get significant heating to a depth of about 1 centimeter. Okay, so 1 centimeter is as deep as far as a clinically relevant temperature increase is concerned. So when you're looking at being able to mobilize tissue, there's a certain tissue temperature you have to get to. If you're treating a really large area and that area is very deep that you're trying to hit, you won't get that temperature increase. You will get a temperature increase superficially, which does have benefits, okay? Now, when you're talking superficial and small joints, yes, you will get a clinically relevant temperature increase. Deeper joints, bigger areas of the body, you're not going to get that significant temperature increase. However, the superficial increase in temperature will still have some therapeutic benefit. So that's an important thing to know. So unlike cold, which you will get tissue temperature decrease significantly at deeper tissue, superficial heat you will not. Okay, so these heating modalities we'll be discussing will only significantly reduce temperature at a depth of about 1 centimeter. So as we look here at some of the physiologic responses to superficial heat, so you're going to have an increase in local blood flow. So the increase in local blood flow, one is going to result from capillary vasodilation in the area. So you're going to get relaxation of the smooth muscle in the arteries. You're also going to get there's also believed that a spinal reflex will also contribute to a vasodilation effect, so that will add to an increase in blood flow. There's also an increase in permeability in local tissues, particularly the lymphatic vessels. Your fluid viscosity is going to decrease, so that's going to also result in greater blood flow to the area as well. Now, one thing to note, it is possible that this could be a problem with acute injuries. So think about the issue with an acute injury that could occur with this, okay? So there's the belief that by increasing the local blood flow acutely in this fashion could possibly exacerbate some of the secondary effects of the inflammation process. So that's something that, again, you have to look at as far as how you're going to apply that with, if you are going to apply heat, think about what you're doing in regards to the timing of the injury and how it may be affected. We know that we're going to reduce pain with superficial heat, and again, there's a couple different mechanisms that it's proposed that this can happen. One is that the physical sensation may activate A beta fibers, so there is a gating effect associated with this. However, because there's other physiologic effects of heat, they don't think that that's the only reason why you will get pain reduction. The other application of this is that since heat is actually carried by your pain fibers, both the A delta and C fibers, it's possible that you also get a descending pain modulation as well. So that input from the nervous system via those small diameter fibers also believes that descending models play a role with this as well. So, when you look at the application of heat, 20-minute treatment can possibly, have a calming, sedating effect, and that these other pain regulating mechanisms we have can become important in the modulation of pain. Analgesia may also result from a decrease in what they call congestion in the area. So in other words, they believe that applying superficial heat can help reduce the mechanical pressure on the nociceptive or your pain fibers, and also kind of help in washing out the different chemicals that cause increases in pain. So, again, a lot of these effects are more than likely combined with what goes on with heat, but they also believe that to be another possible mechanism behind pain reduction. And we also have the reduction in spasm, because like cold, the application of heat also affects muscle spindles. Now, it's going to affect the muscle spindles from a different perspective. So while the cold is going to decrease the sensitivity of the muscle spindles just through the decrease in temperature, when heat is applied, the sensitivity of the muscle spindles also decrease. However, the temperature of the muscle spindles usually aren't affected. So what they think that the reason why the muscle spindles will actually decrease in sensitivity, thereby helping to reduce spasm, is that it's more of a spinal reflex mechanism. So that, again, in the dorsal horn of the spinal cord, you're going to get a mechanism to where the output, the motor output from the spine is going to be decreased with the application of superficial heat. Just some other general effects, if you look at the increase in blood flow, just kind of going back to that really quick. Obviously, you're looking at increased nutrient delivery with the increase in blood flow, and also an increase in the white blood cell response in as far as increased blood flow is concerned. So just in looking at superficial heat in general, your physiologic responses, other physiological responses that we have not discussed. So increased metabolic activity. So obviously if you're decreasing metabolic activity with cold, you're going to increase it with superficial heat. Again, is there a possible detrimental effect with that on acute injury? That is very possible. However, again, you're probably not going to be applying it in those instances anyway. Increased circulation, which we already talked about. You will actually get increased inflammation with superficial heat, improved or increased tissue elasticity, and decreased viscosity in the tissue. So obviously the decreased viscosity in the tissue is going to have an impact on the elasticity of the tissue. Muscle strength and function is generally not affected, so they really haven't shown anything, unlike cold, where it's shown in some studies that it has negatively impacted it. However, so a lot of times people will look to use heat to warm up prior to activity. Superficial heat's not the best way to warm up a muscle. You're going to get much better warm up in the muscles by doing physical activity. So that's something important to note. Once your patients, if you're starting your patients on heat to kind of warm tissue for mobilization purposes and just that general relaxation effect, once they're kind of their pain has significantly decreased, look to have them do physical activity if they can and if it's applicable with the region prior to you mobilizing. Now again, depending on the region you're treating and everything else, that may not work out as well, okay? So say for instance you're in the subacute, latter stages of say a muscle strain. Instead of putting superficial heat on the muscle prior to stretching, mobilizing, massaging, whatever it is you're going to do, have them warm up on a bike. They're actually going to get a better increase because now they're going to get more of an increase in the deep tissue, particularly for a larger muscle, than they would than applying superficial heat. General treatment recommendations for superficial heat, you're looking at a 20-minute treatment. Most of the beneficial effects have been found with a 20-minute treatment, so that's plenty long enough. You can go a little bit longer if you would like, but we're just going to stick with the 20-minute treatment. Most regions of the body will respond to that length of time. And again, just when you're looking at other types of pain, think about the area you're treating. So again, for someone who has maybe like acute low back pain, you could probably still apply like a long duration, low level type of heat because you're not gonna create any type of major inflammatory response in the deeper tissue. The long duration, low level heat, if you look in this picture, now it's not of the low back, this is an example of a long duration wrap that just delivers a very low amount of heat consistently to the area. It's very good for, just reducing some pain and spasm. That's an application you could have there. If you have someone with myofascial pain, like is very common in the upper trap neck area, there tends to be a better result with a shorter duration type of moist heat. So again, how you apply heat could be dependent upon the body part. And again, just use sound judgment with the application of heat. So again, think of the body part you're treating, think of the where they're at in the healing process. That could all dictate whether or not you would use heat. So one of the things, and we'll be discussing this later, is, well, how do you, do you use cold, do you use heat? We'll talk about that and kind of work through some different aspects of that at that discussion in class. I'm going to make a brief mention of what's called contrast therapy. So contrast therapy, if you have not yet seen it, is the alternating application of cold and heat. So the classic way of doing this is you have a warm whirlpool, you have a cold whirlpool, or a cold ice bath, and what you literally do is you alternate between putting the body part in the heat and then putting it in the cold. The initial reason why this was done is because they thought when, early on with treatments, we thought that this would reduce swelling by creating a pumping action, meaning that you would get these cycles of vasodilation and vasoconstriction, and that would then reduce swelling in the area. Well, what we found is that there's actually little vascular response that happens when you do this, primarily because most of it's going to happen in the superficial tissue. So as you're alternating between the heat and cold, you really don't get a vascular response in the deep tissue to eliminate swelling. You will get vasoconstriction and vasodilation in the superficial tissue, but that's not going to impact the deeper tissue. Plus, we know that swelling is essentially reduced via the lymphatic system. So it's not going to impact the lymphatic system significantly. Thereby, you're not getting a vascular response that's significant to reduce swelling. Now, it could possibly be effective in reducing edema in subacute foot and ankle injuries. However, it's not through a vascular response. So the thought potentially is that the contrast baths may decrease pain and spasm through, again, pain relieving mechanisms caused by both the, application of cold, application of heat, and that thereby you could then possibly create motion, which would reduce swelling via lymphatic drainage, because we know as we move the body part, that will assist the lymphatics in helping to remove swelling, because the lymphatics work through muscle contraction. So theoretically, yes, that could happen. There's a small amount of research out there that may have shown that. However, overall, the evidence is not convincing. Not to the point where you would actually have an effect as far as decreasing swelling in the area consistently. So while theoretically it can work, some people anecdotally may have had benefits with that. There's not a lot of convincing evidence kind of showing that that actually takes place. Another very common thing utilized are what are called topical counterirritants. So these are various types of lotions and rubs that cause a sensation of cooling or heating. So here you can see an example here in the picture. There's all different types. I'm not going to get into all the different types. In some way, shape, or form, they create either a cooling or heating sensation. Some claim to produce both. The idea behind, though, there is that there's actually no change in tissue temperature. So these do not cause a change in tissue temperature, but what they do is they have some sort of agent within them that creates a sensory response. Okay. Now the idea behind that is that rubbing a counter irritant may stimulate large diameter afferent input. So what that means is you're essentially using that level 1 pain control by utilizing these topical counter irritants. So they will reduce pain. Okay, they are effective in reducing pain, just not for the reasons that we commonly think. Okay, so you'll hear it in commercials. They talk about, oh, it heats. It doesn't actually heat the tissue or cool the tissue. It's just essentially creating that sensation, thereby which can reduce pain through that large diameter afferent input or your level 1 pain control. And again, when combined with other medications and treatment, they are a good complement to pain relief. Okay, so they can reduce pain. It's just a matter of understanding how they do it. Okay, so just to summarize this section again, understand the physiologic and therapeutic responses. So again, all those physiologic responses I talked about, make sure you can understand those. Again, the key with this and any type of modality is using clinical judgment. And this is going to be some of the things we talk about in discussion, and hopefully you come with questions about, as far as, well, how do we determine, or what are ways we can determine how and when to use heat versus cold. And again, just understand, and this is going to be the case with a lot of things. There's still some research that needs to be done. So again, we'll continue to look at evidence on this to kind of determine effective treatments.